A very good afternoon, everyone. My topic is microbial keratitis and antibiotic sensitivity pattern, a retrospective analysis in central India. As we all know, microbial keratitis is a suppurative inflammation of the cornea and is a major cause of corneal blindness. Almost 1.5 to 2 million cases globally are affected by microbial keratitis, and the similar picture is also present in India. Because of its rapid progression, it leads to a potential blinding condition. It can be caused by bacteria, virus, fungi, or a parasite. There is a regional variation because of the influence of various risk factors and climate. Also, a seasonal variation is seen. So it is important to analyze the recent pattern of etiological agent in a geographical pattern. And this will help in an evidence-based decision in choosing the appropriate empirical therapy. The aim of the study was to report the infective keratitis, microbial profile, and antibiotic sensitivity pattern at a tertiary part of central India. It was a retrospective study over a period of 2 years, August 2020 to June 22. And the study reviewed institutional board review approval from the Institute Ethics Committee. We defined infective keratitis as patients having corneal ulceration with loss of corneal epithelium and underlying stromal infiltration with suppuration, with signs of inflammation with or without hypopyon. All patients or diagnosed cases of keratitis was included. Patients coming to the OPD were included in the study. We excluded patients with sterile neurotropic or autoimmune keratitis and less than 1 month follow-up or nil microbiological intervention. Along with that, we did a standardized form filled up documenting of the cases with ocular history of trauma, contact lens wear, corticosteroid use, systemic illness, corneal findings with proper diagrammatic documentation, socioeconomic details, and predisposing factors. The corneal scrapings were taken by a surgical blade number 15, and it was inoculated into blood agar, chocolate agar, along with gram, GIMSA, and KOH. It was sent for the microbiological lab where it was incubated for 37 degrees, and then later on when the biological culture plates had almost 10 colonies, it were tested for antibiotic sensitivity testing. The other thing different that we did at our center was we used the Vitek technique, which could give results of the antibiotic sensitivity pattern in 6 to 12 hours. No financial interest. The results that we came across, there was 455 patients who met the criteria, and out of which 143 were male and 93 were female. The distribution was 233 patients were culture positive and 221 were negative, out of which the pure bacterial culture was 83, that is 35% of the total, and pure fungus was seen in 146. Rest 2 cases we came across was a mixed microbial growth. Along the bacterial isolates, the gram negative were present in 45 and gram positive was seen in 40. Along the gram negative, the pseudomonas was the most common, and that was the most common bacterial in our isolate. Staphylococcus was the most common gram positive, followed by bacillus. Streptococcus was the third gram positive bacteria. Fungus was the overall most common in our isolates, which was 60% almost, and unidentified hyaline fungus was seen in 83 cases, aspergillus being the most common and followed by fusarium. The antimicrobial sensitivity profile was documented in 3 organisms, Pseudomonas, Staph, and Strepto. Along this, in the Pseudomonas, we found that 89% was sensitive to colistin and 65 to 75 resistant was seen to most of the antibiotics. Staphylococcus had 100% sensitivity towards Vanco, imipenem, amikacin, and 80% towards Genta. It showed 65 to 70% resistance against Levoflox, Erythro, and Ciplox. Streptococcus was 100% sensitive to Vanco, chloramphenol, Cefta, and 66% resistance to Levo and 33% resistance to Moxi. The discussion, the clinical outcomes and microbiological patterns and epidemiological patterns may be different from country to country, and it may be different in different regions of our country itself. So analysis of different patterns in particular area is important for making the decision for the empirical therapy. There are many papers regarding the different geographical documentation of the ulcer patients. In Madurai also documented Streptococcus as main organism. Another study from South also documented Streptococcus, and they used the Kirby-Burr disc diffusion method for the antibiotic sensitivity. Then another for South India, Streptococcus. This is from the eastern part, which showed Staphylococcus as the most common. Delhi, a major study which was done showed Staphylococcal. Along with that, there are recent study where it was a multi-centric study, and our institute had also participated. There also Staphylococcus was seen more in the north and Pseudomonas was seen in the central India. The limitation is use of the Vitek technique, and also because of the loss of follow-up of the patients and remote areas, we had a limitation and the sample size could be more increased. The Vitek technique also is more used for the generalized use, and ophthalmological formulations for most of the antibiotics is not available. Conclusion, although it was a central, based on a central only single center, but it is definitely can give a current pattern of the infective keratitis, and a structured protocol can be taken for the empirical, and also the overuse of antibiotics can be restricted. Along with that, integrated ophthalmological and laboratory services can help in future development of the resistance. Thank you.
Yeah, good study, but I wanted to ask, you have considered, you have compared with different areas, geographical areas. Have you compared with different generations? Like, have you referred to previous papers of the past where, has there been any change in the sensitivity pattern over the years?
Of course, sir, there has been a sensitivity
So
pattern.
that has not been mentioned.
No, sir, that has not been. I just stuck to the main part of my study, which were giving the epidemiological pattern. And so the resistant pattern had not been documented in this study, but we have written a paper about that. It is yet to be.
Because most of your references probably are from the past. So
Yes, yes, sir.
So did you?
So one study that I showed was from December 2022, which it was a multi-centric study, and our institute had also given data in that.
Okay. Yeah. But next time, stick to time, please.